just say
1, 2, 3, 4.
We're here today with two of the leaders of the American Academy of Ophthalmology, and we're here to talk about a very exciting project, one that is trailblazing in many ways. What I'd first like to ask you, gentlemen, is how did the idea for this database come about? David?
Well, I think it was something of a group decision. It wasn't one person with a light bulb coming on. I think that Bill has been very interested for a long time in quality of care. And we realized that a lot of the vehicles that were out there they were more sort of ticking off the box than they really were moving the needle in terms of improving patient quality. And we were aware of registries that existed in other specialties, but they had a lot of limitations for an outpatient environment. They were mostly hospital-based, and they weren't longitudinal, following patients over a long period of time. And the diseases that we take care of as ophthalmologists are chronic diseases, macular degeneration being the classic example. And if you're going to follow how a patient is responding to therapy and what the impact on their life is of macular degeneration and your various treatment options, it's going to be a multi-year process, and it may be a multi-doctor process. And so we were sort of brainstorming as to how to do this, and Bill has a lot of knowledge as to what thoracic surgery has done with their database, and I think it was probably sitting down over multiple, glasses of wine or whiskey, and other people, not just, I don't mean to imply it's just the two of us, and we came out with a set of guiding principles. It had to have clinical relevance. It had to be low hassle for the doctors. It had to be confidential, private. It had to have data security. It had to put data points in that we'd be able to analyze for meaningful results. And it had to have an incentive for the physicians to want to participate. And out of this grew a task force that Bill chaired. And that was in late 2011, if I'm correct.
That's correct, yeah.
And we are 4 months away from launch.
I think the other thing, David, was the confluence of several other factors. The vision, and really a historical commitment to quality and outcomes. We were the second specialty actually to develop evidence-based guidelines in 1985. We tried to launch a registry in 1997 to measure the surgical outcomes for cataract, glaucoma, retinal disease. No one wanted the data, shockingly. And the big thing was there was no IT to enable us to do that. If it was successful, we'd still have the limitation of looking at an intervention in time. And our vision was to, what is the impact of that intervention on a patient, whether it's a surgical procedure, a drug or a device, on the longitudinal care of that patient. And we found a way to do it. And thoracic surgery and cardiology look at interventions, but they don't know what happens to that patient 90 days later. So this is the first time where we're going to be able to assess, not only improve our personal performance and our outcomes, but to really assess the best practices going forward on how to treat disease. So it was that vision and IT, and the IT changes that enable us to activate the registry. For myself, I've been surprised and a little frightened about the interest. We had a goal of 2,000, David, in 2015.
Yeah, 2,000, 2 years from now.
And 2,000 docs in 2015 will give us 18 million patients in a database. Imagine the power of evaluating effective processes of care. And we might hit that 2,000 goal before the launch. So the rewarding thing to me and about the docs is they're not afraid to be measured. They're embracing this. And I think too often physicians are afraid to improve. You got to measure yourself first. And as long as you have the chance to do that, see how you compare to your peers, you will respond. I think a lot of physicians are afraid of public reporting as they get their first measurements. I think you need a time to improve, solidify your goals, solidify your outcomes. Then you can do with the data what you want.
Because traditionally, when measuring doctors, the doctors complain, they say, my patients are sicker than your patients. My patients have comorbidity.
Oh, you've heard that?
You can't compare.
Yeah.
How do you deal with that with the ophthalmologists, with your colleagues?
I think the first thing is this is being done by their professional society. It's not being done to them by an outside black box. And so there's a sense of, you start with a certain reservoir of trust, and you also realizing that your own colleagues are putting this together. We know what risk adjustment
Absolutely.
means. We know what the important cofactors are. We're having the measures built up by people they trust, that they work with, whose papers they read. And we also understand that it is a little bit of a garbage in, garbage out situation. And if we don't appropriately risk adjust it, not only do we have a useless instrument that'll fail, but it also will impair their trust in the academy. So we have a lot of incentives to do this right.
Exactly. And the ability to risk adjust, that is the major difference here. I will be able to compare, for instance, my patients, if I'm working in a Hispanic area south of Florida, in southern Arizona, where there's a high number of Native Americans and Hispanics with bad prognosis, I'm able to compare my subset of patients to a similar subset of patients in Southern California or Florida. So the ability to actually look and define your populations hasn't really been done with that degree of granularity. That gives doctors a real chance not only to improve personally and increase outcomes, but to really address populations at risk with adverse outcomes now, which we really haven't done a very good job of. Yeah.
You know, I think I'd emphasize one thing that Bill said before is that, you know, the ophthalmologists are not different from any other physician in that we really do want to do a great job. And we're all type A. And so when you see yourself measured by an instrument that you think is valid, and it says you're below average or you're below optimal, you're going to say to yourself, how can I change?
Our mothers never thought we were below average. And so it's important that we carry that forward now. And I was convinced that physicians, if they thought it was fair, if they thought it was equitable, if they thought it was risk adjusted, they would not be afraid to be measured. And the response has really been incredibly encouraging.
Now, this data will be kept by the AAO. Now, as you know, Center for Medicare Services, Health and Human Services Administration, they're pushing to get data. Will they be allowed to get this data? Is that part of the vision?
I think we'll two-time you on this.
Okay.
I own my own data, my identified data with my patients so that I can improve. Mm-hmm. So I'm comparing a subset of my macular degeneration patients with certain risk factors to a national number. So those identified patients belong to me. CMS, in order to be rewarded for quality improvement, wants identified data sent to them. So if the physician wants to participate in PQRS, value-based modifier, and all the other new value-based initiatives, the registry will forward that data to them. So CMS only has access to the data that you voluntarily forward to them for quality measurement. Aggregated data?
The Academy sees no identifiable data. That's really important for both patients and for physicians. You know, we're not sitting there in a room swept for listening devices and saying, you know, look at Bob, he's really doing a bad job.
Yeah.
The only thing that we're seeing is de-identified, aggregated data that we need to be able to build the benchmarking tools, to be able to help looking at practice trends, to get involved in clinical trial setups, the things that we need to do to support the infrastructure of the registry.
So the next question is, what about patients? What are the benefits of this database for patients?
Well, the primary benefit is that we, as the physician who's working with the patient in a team to try to manage their disease in an optimal fashion, we as the physician are going to have data that we've never had before at a very, I'm going to say, very granular level to help make the best treatment decisions based on the best available evidence. And it's not just going to be the medical issues. We'll be looking over time at issues, for instance, at functional quality of life implications, the impact on the lives of patients that do have macular degeneration. So this has very, very real impact on patients.
This is actually, people talk about genomics and individualized approach to care. This is the best hybrid that I know of, that we're going to have massive amounts of data that we can reference that individual patient in front of us and figure out what's the best care for them. And I think that's incredibly powerful. So the patients are going to individually benefit from the knowledge that that physician is going to have in picking the best treatment and the best course of care. I think that we're committed to not just looking at the numerical outcome, as David said, of, well, 95% of my patients see 20/20 at 3 months after surgery, or 90% of my new macular degeneration patients maintain 90% of their vision 6 months later, whatever. We're actually, part of this, as David references, patient satisfaction done independently surveyed, and patient-reported outcomes. Mm-hmm. Does it make a difference? What we consider an outcome, does it really make a difference to the patient in their life? Does it really improve what they're doing and what their expectations are? I firmly believe in the power of patient-reported outcomes, and it's incorporated into the outcomes modules of the registry, and that's also very unique.
So the third wheel is research data. Mm-hmm. Does IRIS incorporate or capture research data?
The answer is yes, it can, but it's all research projects have to have an objective set up. And so once you figure out what you're trying to study, then you understand what the inputs have to be, what data points you have to collect. Exactly. The thing is that registry-based data is fantastically powerful because you get to large numbers so quickly. I mean, as a retina specialist, and if you go back and you look at a lot of the retina trials, they're based on 80 patients, 250 patients, 1,000 patients. As Dr. Rich said earlier, we're going to get to 20 million records. And when you have 20 million and you look at the frequency of macular degeneration, you realize you've got millions of macular degeneration records. So you'll be able to approach research not with a huge blunt club, but with a very sharp knife to try to get to the differences that will matter for individual patients.
I think also there's a realization that we have to go beyond randomized clinical trials, which are really defined populations, homogeneous populations, and then you're off to the races treating a heterogeneous group of patients. And I think the recent article in the New England Journal that David brought to my attention is incredibly powerful, the ability to bring in patients in clinical trials. For instance, the financial aspects, David, of expanding it. What did the article in New England is about $50 to bring in a new person in a randomized clinical trial? That's unheard of. That's unheard of.
You know, many trials that we're talking about, it's thousands of dollars. And so then the other thing that's very important to patients is the trial that may take 5 years without a registry to get to enrollment. If you can get to it in 2 years, you've got the data 3 years earlier, and there's a lot more patients who can benefit from it.
Also, there's a tremendous ability of this. The Food and Drug Administration now is under a lot of pressure to evaluate the long-term benefits of devices and drugs. But if we emphasize on devices, 60-some% of Class 3 devices are mandated post-market registry surveillance. And the FDA would like those not to be private companies where the individual device manufacturer has the data, but they're encouraging clinical registry to do this work. So we'll have the ability to do device surveillance also, which is very, very fascinating.
Because you're familiar with the whole issue of dark data, this vast pool of data that's never published. And there's been a lot of efforts underway in other medical specialties to get all researchers to disclose all data, even if it's not nice and not particularly positive. Clearly, what you're doing will address that as well.
It will, and frankly, that was the intent of There was just a work group put together by Pew to work with the FDA. How do we get, cleaner data for device surveillance? And to get that data done by independent registries is a very powerful move to make the data more transparent.
Do you think other medical specialties could learn from what you've done?
I think that we're not unique in trying to pursue clinical registries. And I think each specialty has some unique issues. If you're based in a hospital and you do a very limited intervention, let's say like a cardiovascular surgeon, that's why the type registry they've had for a while has worked for them. I mean, they're focused on very short-term outcomes, and very appropriately so. By the way, they're now looking at more longitudinal registries.
Right.
And if you're, let's use oncology as an example. They have a much more complex problem, because if you're an oncologist dealing with a patient with, let's say, lymphoma, you may also be seeing a pulmonologist, a cardiologist, a neurologist, and so you've got to pull data in from so many areas and so many different facilities. We in ophthalmology do have something of an advantage here, because in general, for the diseases that we really focus on, macular degeneration, glaucoma, cataract, diseases like this, it very frequently is just the ophthalmologist. And most of it happens either in the office or in an ambulatory surgery center, so we don't have as much of an imperative to have to get the big facilities involved. So we have some unique advantages, a few disadvantages, but I think that, and in fact I know that if you look at all the other major specialties, they're either pursuing a registry or they're engaged in a discussion as to whether they should pursue a registry. One of the things that I credit Bill and our task force for is that one of the things they put right up front was doctors aren't going to use this unless there's a very strong incentive. And one of those is that the hassle of data input goes away. And that's one of the things that ours is structured to do. Once it's set up, the data uploads in the middle of the night. It's not a doctor having to finish seeing all his patients during the day and saying, gee, I have to take another hour and a half and put my data in the registry.
So how did you accomplish that, given that there are a myriad of electronic medical record systems out there?
Great question. We benefited from learning from other societies that have done this, and we were looking for a technology that would affect exactly what David said. And there's something called a systems integrator. In the United States, we've been waiting to have common data sets across the EHRs. Forget it. So we found a software system actually used by cardiology called a systems integrator. It's EHR agnostic. It will sit on top of any EHR, map the data elements that you want, feed it into the registry and back to the individual physician. So we found a bridge rather than waiting for this theoretical informatics advance where we're going to have common data points. I don't think it's ever going to happen. So we found that bridge to seamlessly upload data out of many different EHRs. We've now uploaded out of 12 different EHR systems. It's very exciting.
So for an ophthalmologist who enrolls in this program, what are the steps? They have to get a hold of a systems integrator. What is the process for them and the time course in general?
Bill?
Well, what they can do is they just go online to the Academy website, and they can look up IRIS Registry. We have a lot of fact sheets to tell you what the process is, what the benefits are, what the responsibilities are. You can download a contract. We sign that contract with the Academy, and we then introduce them and we ask them to identify a contact in their practice that can answer questions about their EHR. And the Academy and the vendor actually will then interact with that practice, and it's called mapping. They pull the data elements out, and usually the first night they collect 85% of the necessary data of hundreds and hundreds of data elements. And then it's an iterative process, usually 2 to 3 phone calls after that to find the other 15%. So basically, they contact the Academy hooks them up with the vendor, and so far it's worked pretty seamlessly.
Who pays for it?
The Academy does. The Academy has borne all the costs of development, and the Academy is not charging the first 2,000 members who join up because we think we need to demonstrate the value. And the best way to do that is to get people engaged, and we want to remove all reasonable barriers.
Exactly. I mean, the whole quality thing, we're not unique, but we do have a long history of dedication to quality. And so this is part of our culture. This is one more step. And this gives us, the physicians, as David said, without an impediment, a financial impediment, to demonstrate that this really works. So right now there is no charge. I think it's maybe the largest financial expenditure the Academy's had in its 100+ year history. So we're serious about it.
Yes. This is something that, and it's not something that we build and it goes away. This is something that is going to be a living product where we add new data fields, that we improve the product all the way along. And as Bill said, we consider this part of our core professional obligation to do this for our members and for their patients.
I think I've been in practice now, David, 37 years. And I look at how I made decisions on that patient in front of me. And I don't have that much of a career left. I just wish I was starting practice now. This is powerful.
Patients who are watching this and say, I want my ophthalmologist part of this database, can a message for them, or whether that's superfluous?
You know, I'd rather not go there, and I'll tell you why. Is because we're not trying to force this down our members' throats. We want them to go to this because they want to, and we think they will. We know they are. We've already got more than we can handle.
Yeah. So it's been a ride.
Yeah.
Just starting.
I just want to wrap up and say, Dr. Parke and Dr. Rich, thank you so much for telling us about this extraordinary land-breaking project.
Thank you, David.
Thank you very much.